Top Med Talk.
Hi, it's Monty Mython here, Editor-in-Chief of Top Med Talk. Well, these are extraordinary times. Despite all the challenges we face, we will continue to deliver free, open access medical education for as long as we can manage it, as well as our new regular updates on COVID-19, the global pandemic of coronavirus. Reporting from the front line, we'll be concentrating on enhanced surgical recovery. Why have we made that decision? Well, with an unprecedented pressure on resources, many institutions have decided to accelerate their widespread adoption of enhanced recovery. And why? Well, it's never been a more important time to reduce complications, readmissions, avoidable ITU bed occupancy, and to get our patients home fitter and faster after major surgery. As somebody who's about to get back into the trenches in critical care, to all my surgical, anaesthesia, and perioperative care practitioners, thank you for making this a priority. A big shout out to our sponsors, in particular Edwards Life Sciences, who have very generously agreed to continue to support this resource, that's Top Med Talk, at a time of global need. We're all in this together. We will get through it. It's going to be fine.
This piece is presented by Dr. Daniel Engelmann, a thoracic surgeon in Springfield, Massachusetts, affiliated with the Baystate Medical Center. He received his medical degree from NYU School of Medicine and has been in practice for more than 20 years. Have a listen.
Good morning, everybody. Thank you for inviting us to speak. Yes, tie, yes, surgeon. But we banned ties, actually, on all of our surgeons in the hospital because we realized that secondary to stethoscopes, which we never use, this was the number 2 fomite for infections. So we have to use them somewhere, so I pull them out of the closet for your meeting. But so I'm going to give you as brief as a surgeon can be, which isn't very brief, summary of enhanced recovery and cardiac surgery. So I'm not speaking so much about what I do at my institution, but more about what cardiac surgeons around the world have done, because we've attempted to cohort this small group of very flexible individuals in one group. So you can see what happened there. I do have these relevant financial relationships which allow me to run around the world and try to spread the word. So all this started literally 2 years ago in April of 2017 when myself and a group of other fellow cardiac surgeons from Cleveland Clinic and Nashville, Montreal Heart, and we got together. The guy next to me is my father. He's also a cardiac surgeon. There's a little nepotism there. But whatever it was, we plopped right in the middle of our national meeting what we call the Enhanced Recovery After Cardiac Surgery Society. We've since changed our name to ERAS because the ERAS Society didn't really like that. But that said, this is where we first started. We got a group together about this size, and we asked, is there any interest in cardiac surgeons working together? And we had tons of interest, so we put together a board, and after a million phone calls and conferences, we came up with one sentence, which was our mission: to optimize the perioperative care of cardiac surgical patients through collaborative discovery, analysis, expert consensus, and dissemination of best practice. But we then quickly expanded, and we took our executive board, got a bunch of younger people involved who actually had some time to do a little work, and then we dropped everybody else down to the advisory board and then took on an entire group of subject matter experts from around the world, all of which we engage with through multiple communications, and we hence came up sort of with an overview of what we wanted to do internationally. Very inclusive. Anybody who has interest in ERAS cardiac, we want you on board. We want to involve everybody. So this was sort of our outline steps of really what we considered key components, which was just actually published out of our Duke affiliate. Dr. Judson was the lead author, but he came up with this 20-step pre-op, intra-op, and post-op components of ERAS. A lot of it's all the stuff that you guys do in other specialties, though we do have specific things that are different in cardiac compared to what you can do. We don't do very well with non-steroidals, especially ketorolac. We have a little bit more fluid shifts, a lot more fluid shifts, blood utilization issues. There are little differences, but they're subtle, actually. When you really look at them, it's all the same stuff, really. So then we came up with a expert consensus manuscript. We decided to go with utilizing what already had been published by the American College of Cardiology and our Surgical Society, and use their class of recommendation and level of evidence. And after a full Delphi method and 2 years of work, we came up with 23 separate recommendations with a manuscript, which is now fully embargoed, so you're not even allowed to read this slide. But it will be coming out soon. But there are other things that you guys wouldn't have in your guidelines, like our only class of recommendation 1A is tranexamic acid or Amicar during on-pump cardiac surgical cases. This is just not something you guys would be jumping on. But it turns out it hadn't actually even been graded. Some of the other interesting ones which we threw into this was using chemical thromboprophylaxis, because up until a few years ago, cardiac surgeons said, my patients don't get venous thromboembolism. It turns out they get a lot of that, and their patients are not at risk of bleeding. It turns out after cardiac surgery, they're hypercoagulable, and that as soon as they stop bleeding, they all need to be on a chemical, and that pneumatic compression stockings just don't cut it. So that was an interesting little component that we had to add that you guys all think of as obvious, but cardiac surgeons don't. And then there's all types of other ones. It goes on and on. Some of them interest me more than others. The top one there, the early detection of kidney stress and interventions to avoid kidney injury, is a 2A-B recommendation. That's my favorite because I've effectively eliminated acute kidney injury following cardiac surgery with that strategy. Some of the other ones that are really going to shake up the societies when they come out are right after that, the rigid sternal fixation recommendation as a level 2. That's a big deal because cardiac surgeons like to use wire cerclage, and rigid sternal fixation has an inherent cost involved. So that's a big deal. And the prehabilitation one's also groundbreaking. One of you hinted at this. That's number 3 there. And basically what I'm getting at, and I haven't really spelled it out yet, but elective cardiac surgical patients need to wait 2 to 5 weeks prior to cardiac surgery in order to prehabilitate to reduce their post-op poor outcomes. And those are patients with any degree of immobility, frailty, malnutrition. Smoking cessation needs to be a component, hazardous alcohol use, and high hemoglobin A1C. All those patients need to go to prehabilitation, and cardiac surgeons do not like that recommendation because as soon as they see a patient, they like to put them on the schedule the next day so their partner doesn't steal them and do the case. But that's just the truth, and that's what we did. Here's our first publication that's now out in the Journal of Thoracic and Cardiovascular Surgery. We have a book chapter coming out there that sort of just summarizes stuff. We were the cover of the nursing journal, which points out the importance of collaboration involving our nursing cohorts. And that was just, I don't know how that made it on, but that's the author's baby. Judson Williams had a baby. As he worked on that, I said he needs to stop having babies and publish more. And future publications are coming out. The biggest one is our guidelines, and they're embargoed. We have a how to start an ERAS cardiac program manuscript, a collaborative manuscript of who's doing what. So we're trying to really figure out what the world is doing and take the best of. We also have a complete guide to optimizing outcomes in press. We have a chapter in that. And now we also have a whole critical care clinics dedicated to cardiac, of which we're going to do 8 to 10 manuscripts in that. We have a very exciting website that luckily our sponsors gave us enough money that we could build at a ridiculously overpriced cost, but it really is interactive and lets people really look at protocols and share best practice. And we also put out every 3 months a newsletter, which is useful. And we've also earmarked our first center of excellence, which happened to be Wake Med. And we're going to start by going there and teaching the teachers. So we're going to bring teams. My team from Baystate's going to go there. And we're going to make multiple sites of excellence in order to allow us to teach others and share best practice. And that's a protocol. We are disruptive, I talked about. People don't necessarily like what we say, the cardiac surgeons. We'll see what happens when the guidelines come out because our surgical journals rejected it and said we were not the experts. Put it in the guideline committee and we'll get back to you in 2 to 3 years. And we said that's not going to work. So we went way above them into a much bigger journal. So we'll see how that goes. We fly around the world to every one of these meetings, including yours, to spread the word. And we're all over the place. It's nonstop. And we were finally, our national organizations embraced us instead of fought with us. And at our next American Association of Thoracic Surgery meeting in May in Toronto, they offered me 8 sessions, which is 12 hours, which is unheard of on ERAS perioperative. and the Society of Thoracic Surgeons similarly followed because they're all in competition. So instead of fighting, they've joined us. This is one little message to all the surgeons or those who work way too hard in the room. Don't spend all your time doing this, running around the world giving lectures, because before you blink, your kids grow older and you miss everything. So that's my take-home message. Thank you.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. Have a look, ebpom.org/meetings.